So let me share with you the first case of SPIL protocol. Now here if you see this lady with the problem with the upper jaw, we have placed 6 two-piece DSI implants in immediate load protocol. Now why DSI? Because obviously she's undergoing multiple extractions, some filled endodontic teeth, some mobile teeth, some broken teeth. However, there was no need for a pterygoid implant, no need for removing the wisdom tooth because the zone A and the zone B, that is the pre-maxilla, allowed us to successfully place long two-piece implants which allowed retrievability and also allowed us to avoid a pterygoid or a zygomatic implant, yet giving her an immediate load solution which could be retrieved at a later date to compensate for the tissue shrinkage. How many of you find this something amazing, wherein with this single drill protocol, you will now start placing even your two-piece implants flapless and even then have the complete flexibility to create retrievability by using customized multi-units for such kind of cases. But however, time and again, your clinic will be challenged by cases like this. Now, if you see this guy, not very economically affording, if I may use the word, having impacted canines, which takes away almost the anterior maxilla, which means that if I have to remove the canines, there will be a big defect, which is obviously beyond placing conventional implants or grafting. Having the need to get immediate solution, having some comorbidities which do not allow extensive procedure, yet of course wants to live life to the fullest, given immediate solution with the help of basal implants with the use of intraoral welding to stabilize those implants which received lesser torque because of the extraction of canine, and still given immediate teeth within his budget so that he could refer 3 other patients to the clinic because earlier he was rejected by doctors or given lengthier treatment plans. So similar case, immediate loaded, similar protocol of single drill, but with the option of basal implants, single drill, intraoral welding. How many of you are finding this really interesting? Type interesting in the comment box because the next cases are really going to blow your mind away. Just type ready in the comment box if you want things to get crazier from here. Now look at this craze. BCS-MU, which is the screw retained basal implants in the pterygoid. Screw retained two-piece zygomatic implants, which means you are seeing the first of its kind case wherein the basal implant is now amalgamated with a two-piece implant, which means the unified protocol is getting applied wherein a two-piece zygomatic implant unifies with the single piece BCS MU implant, providing a screw retained solution in the maxilla. In the mandible, the things get even more crazier because as you see in the anterior zone where you see my cursor over here, you see the KOS MU implant. You see this KOS MU implant in the anterior maxilla. You see the BCS MU in the anterior mandible. BCS MU in the anterior mandible, and posteriorly the two-piece conventional implants, which means you are seeing one of the craziest cases wherein a two-piece zygomatic implant amalgamated with the BCS MU implant in the lower jaw, amalgamation of KOS MU single piece, BCS MU, and posteriorly the two-piece DSI implants, all creating retrievable prosthesis, 1 or 2 drill protocol unified approach giving the patient complete retrievable solution, amalgamating the science of conventional implants and basal implants beyond our ego to give something what the patient walked in for, simplistic, life changing. How many of you find this super crazy? Just type super crazy in the comment box. When you're ready, just let me know, and things are going to get even more crazy from here. Look at this case. This lady comes with two conventional implants in the anterior maxilla, failing dentition in the maxilla, rejected by one or two doctors saying there is lack of bone. One or two doctors told her that she has to go for delayed loading procedures, which she was not ready considering there is a function in her family. In the lower jaw, her anterior teeth constantly they get dislodged because the teeth remaining are just root pieces. And now I plan to start the case. I do my zygoma on one side. On the other side, the moment I put the conventional zygoma, I don't get torque. In the chair, the procedure is flipped to a basal zygoma because it has a wider disc at the base, and I get amazingly high torque, which is needed for doing such cases. I complete the other implants with BCS in the anterior maxilla, as you see. In the lower jaw, we place the BCS in the anterior mandible in extraction sockets, and posteriorly, I do a now bypass, which means you are seeing the first of its kind crazy case, conventional implant on the left side, basal zygomatic implant on the other side, conventional zygomatic implant on other side, BCS implants in the anterior maxilla connected to her earlier existing integrated conventional implants, and in the mandible the conventional integrated implants connected to the BCS implants, all keeping the ego aside, using simple simplistic drilling protocols to give her a happy smile. So switching or mid chair adapting of a situation. See, you may feel, oh, but this treatment plan change. Adaptation is the biggest hallmark of a competent surgeon. Mind you, the more surgeries you do, the more complicated cases that come across to you, never you will be able to execute only plan A in all the cases. And what if the system itself gives you a plan B so that you don't have to keep thinking when your plan A fails? Don't you think this is the next generation power your practice needs? Type power if you feel that this is something really powerful given in your hands, where within the surgery itself, you may need to switch a protocol which is already existing for you. You are not suddenly taken aghast. Oh, my sinus is perforated. I have not got torque. What to do? How many of you would be interested in knowing more about such systems, more about such cases? Type me in the comment box. Or you're restricted to the conventional knowledge, what is written in the textbook is my holy grain and I will not grow beyond the textbook. How many of you feel that your practice demands something which is more powerful and realistic, something which can rocket your ROI simply because you are open to innovation and not having a mindset which kind of restrained you from thinking beyond the books? Just type me in the comment box. Now look at this even more crazier. Conventional two-piece zygomatic implants for a resorbed jaw in the maxilla. It's a quad zygoma case. Even the anterior maxilla not available for BCS implants. And of course, when you want to do quad zygomas, you want to have retrievability just in case there are any problems, you want that peace of mind with retrievability. And in the lower jaw, the resorb mandible, wherein the all on four was not possible in the anterior mandible because it was ultra thin and fragile, managed with BCS implants and intraoral welding to give this lady an amazing smile. How many of you have seen the video of this case also, which I posted on the social media? Imagine a system which gives you the flexibility to do this. This is beyond what is existing right now in any books. This is pure hardcore practical management of most complex cases in the most simplistic ways. How many of you want to see something even more crazier? Type me in the comment box. How many of you want to see something even more crazier? Type crazy in the comment box. Look at this case now. Economics was an important factor for this lady. The upper jawbone extremely fragile and thin. However, the prosthetic space, which means the interocclusal clearance, was too less to place upper and lower cement retained prosthesis. So I need to take care of economics. I need to take care of a fragile bone. I need to take care of retrievability in the lower jaw, especially when you're removing large molars. There could be tissue shrinkage. I need to manage prosthetic space, and I need to leave my ego aside while working. What's the solution? Single piece cement retained basal implants on top to get the economics down. Screw retained basal implants in the bottom to allow retrievability, and more importantly, prosthetic platform management, because you need a minimum of 25 interocclusal space to successfully make upper and lower cement retained prosthesis. And by switching to a lower screw retained and an upper cement retained, I created a prosthetic situation which eased the workflow and gave better aesthetics to the patient, and also took care of the patient economic factors. How many of you find this super crazy? Just let me know super crazy in the comment box. And are you ready for something even more crazier? Just let me know ready in the comment box. Look at this case. Only a crazy person will put the hands in such cases where OSMF patient unable to open his mouth to the complete extent, comes for implants or for fixed teeth, doesn't want to undergo the complete mouth opening because it was another 1.5 to 2 lakhs expense. And I knew I could provide in something which will work. What we did is in right in front of you, upper jaw, cement retained basal implants, lower jaw, right side mandible, BCS MU, DSI implant, which is a two-piece implant, screw retained next to it, all dependent on the basis of bone available and mouth opening. Next to it is a CIH implant from the Impact R-Line series, connected with a multi-unit, a BCS MU in the anterior mandible, a DSI on the right side and another DSI on the right side, giving a screw retained prosthetic which takes care of his extraction socket, and more importantly, allows me to remove his prosthesis, work on the upper jaw, and then simply screw the lower prosthesis back in, which means my maintenance also becomes very easy. How many of you think that this is out of the box and something you can do or think about doing in your practice to take up such cases? Are you even aware the number of OSMF cases in India? So we always keep saying we don't have patience. My challenge or my question to you is, if given a patient, do you have the protocols with you to help such patients? How many of you think that this is something out of the box? Just write out of the box in the comment box. Have you seen on any conference, in any textbook, any kind of speaker presenting to you unconventional ideas, simplified, simply not because you want to sell an implant course or a system, but because I want to update you on an ideology which can revolutionize your practice? Do you agree why I mentioned revolution? Because this is not about conventional implants or basal implants, my friend. It is something which we all can be blessed. We are all already blessed to give our patients, and that is the benefit of making them smile with simple procedures. I know so many of my dental colleagues living with back pain, neck pain, simply because they themselves are forcing themselves to do procedures. So first they will force the patient to get a sinus lift done, and then they will force themselves to do it, even though there are easier procedures existing now. And I'm going to show you follow-ups. I'm going to show you the success rate with this kind of work. It took me 17 years. This is not something which is developed overnight. I have close to 7-year follow-up of most of these cases. Remember, every scientific thing which you are seeing or reading has been put up first time by someone who found it new. I dare you and I challenge you. Are you open to the change? If you are open to this change, just type change in the comment box.